Right, this right. So good afternoon, everyone. This afternoon, I'm going to talk about a new concept. Basically, it's an older concept in a new form, dual mobility cup, and its use in current scenario. So, whenever we do a total hip replacement, what? Okay, it's okay. No, it's not showing the screen. Okay, fine. Apology accepted. Good afternoon again. I'm going to talk about dual mobility cups. Its use in current scenario. Basically, it's not a new concept. It was a very old concept, but it has again reborn in last few years. So basically, whenever we talk about total hip replacement, the most dreaded complication we know and we think about is dislocation. So instability is a disabling complication, and it's the most common cause of revision. And the range, it range from 10% in primary total hip to 28% in a revision hip scenario. And it has been found that 58% of the dislocating total hip replacements, they had their acetabular component placed within the safe zone. So, despite of placing the acetabular component in a safe zone, there are incidences of instability. So, it has been observed that stability is not a single factorial, it's a multifactorial origin. So here comes the role of a dual mobility cup. It expands the acetabular safe zone and decreases the potential of dislocation. So this concept is old, and it was a thought process of two doctors, Dr. Bosquet and Dr. Rambert in 1974. But it was not popularized because of high intraprosthetic dislocation and high risk of wear. But again, it got a second birth in 2009 after FDA approval. Since FDA approved the cup, there has been consistent increase in the number of utility and utilization percentage over the period of last 10 years. So dual mobility cup is basically a tripolar cup. It's an interposition of a mobile polyethylene layer between the prosthetic head and the acetabular cell. And it works basically on two orthopedic concepts: Chanley low friction arthroplasty, that a smaller diameter head produces lower torque forces in the cell and consequently causes less wear, and McFarrar large diameter bearing theory, that large diameter bearing is inherently more stable than a smaller diameter head. So we all are aware of the concept of jump distance. So large diameter head increases the jump distance and reduces the dislocation rates and chances. So this is the basic theory behind using the dual mobility concept. So primary indications, mainly it's used in a specific group of patients with high rates of dislocation. Particularly, the most publicized use is displaced fracture neck of femur in elderly, total hip replacement in a spinal fusion patients, patient with weakness, muscular weakness, poor cognition. And as we are all aware that basically this dual mobility concept was brought in cases of neck of fracture femurs, because and the biggest concern in neck of femur fractures, THR, is high dislocation rate, and that ranges from 2% to 20% in different series. So why? They have a higher rate of dislocation in fracture neck of femur because they have poor muscle power, they have tendency to recurrent falls, old age, poor cognition, osteoporotic bone. So you need some new technique, something new implant to at least reduce the rate of dislocation. So there comes the role of dual mobility. So this is a 74-year-old female community ambulator, fracture neck of femur, right side, fixed with a dual mobility cup, uncemented, both acetabulum and the stem side. Another female, fracture neck of femur, 70-year-old lady, community ambulator, left side femur, neck of femur fracture, fixed with an uncemented dual mobility cup. This is an MDM cup from a striker, uncemented stem and uncemented cuff. 70-year-old female with displaced fracture. Now this is uncemented cuff from Evolitis, dual mobility cup in the fracture neck of femur scenario. Other scenario where a dual mobility cup can be used is a revision scenario, like when you are converting a partial hip to a total hip. in cases of recurrent instability in revision THR scenario. So this is another case where a 70-year-old lady, she had a sudden onset pain, unable to weight with her right lower limb, and she had a history of osteomotor processes done 10 years back. So this is the X-ray where there was a fracture of the stem. So I revised it. Did a ETO on the femur side and used a dual mobility cup on the establer side. So this is a Wagner from Jimmer and dual mobility cup from the striker. So this is a 3 months follow-up study. This is 6 month follow-up. Patient is walking, full weight bearing. Another scenario, 60-year-old male, cemented HRA. Patient had a history of multiple dislocation as close reduction done within 1 month of primary surgery. So this is a pre-op X-rays, multiple episodes of dislocation. So I did a cement on cement on the stem side and on the femur side, and I used a dual mobility cup on the establer side. But this gentleman came to follow up after 6 months following a fresh fall. So he developed a periprosthetic fracture. The implant was very stable. I just fixed it. This is the immediate post-op X-ray, post-periprosthetic fracture fixation. Patient is walking 7 months post-op, full weight bearing. Another case, 72-year-old lady, failed PFN. There was significant damage to the acetabulum. Acetabular erosion was there. My again choice of implant was a dual mobility cup in this case. This is a CT scan showing damage to the femoral head and the acetabulum. In this case, I used a cemented dual mobility cup. So this is the case of cemented dual mobility cup from evaluatus. This is 3 month post-op. Patient is walking, full weight bearing. Another scenario, heavy male, approximately obese, weight around 110 kg, 87-year-old male with non-union IT fracture. Patient was not able to put weight on the left lower limb. So this is again a scenario where I will use a dual mobility cup to reduce the chance of dislocation. This is again Wagner on the femur side and a dual mobility cup on the establer side. This is the immediate post-op X-rays, non-union femur. Another patient, again 75-year-old male, fracture of the stem neck. It was a 1.5-year-old cemented bipolar done. Patient came with there was no history of fall. Maybe it's a fatigue fracture or something, but there was no history of fall or trauma. So just 1.5 year post-surgery, he developed a fracture of the femoral neck. Again, my implant of choice in this scenario is a dual mobility cup. This is the broken implant. I did a ETO, extended trochanteric osteotomy, to remove the implant, used a dual mobility cup on the establer side and a Wagner stem on the femoral side. These are the immediate post-op X-rays. So the biggest question which is being asked in dual mobility cup is that, is it okay to use in young patients? So the answer is that we have excellent short and medium-term results. 10-year follow-ups are excellent. They have comparable rates as compared to normal primary THR and significantly lesser dislocations. But still, we don't have level 1 study. We don't have any randomized data. We don't have any randomized trial. So we don't have any long-term follow-up data to make a bold statement that yes, it can be used. So the take-home message is it's a safe option, durable and effective solution to hip instability. This concept has extensive lab and clinical support, and it can be used as an alternative in high-risk patient population and femoral neck fractures. Long-term data is still awaited to make a bold statement. Thank you. Thank you for your kind attention.